Hey everyone. Today we're going to talk about cardiac emergencies, important concepts, and practice questions for the exam. When you arrive at the scene, your patient may be complaining of chest pain, or chest pressure, or heaviness, or may describe it as an elephant sitting on my chest, or may have an additional pain in the neck and left arm. The problem is there are a few common causes of this chest pain. One is a heart attack or an acute myocardial infarction, AMI. Another is angina pectoris, either stable or unstable, and we'll talk about that later. And another one is congestive heart failure. In the field, you may not be able to tell what's the cause of the chest pain. But there's a term that describes the chest pain from any of these causes, and it's called acute coronary syndrome, ACS. So here's a practice question. An 87-year-old male is complaining of a pressure in his chest for 30 minutes. Before obtaining a history and physical examination, which of the following is most likely? A, an acute myocardial infarction, B, angina pectoris, C, congestive heart failure, or D, acute coronary syndrome? Well, since you're not sure at this point whether it's an AMI or angina or congestive heart failure, the correct answer here is acute coronary syndrome, ACS. Let's do a quick review of the heart. The heart has 4 chambers, 2 atria at the top that collect blood, and 2 ventricles at the bottom that pump blood. And if you look at this picture and the green boxes, you'll notice that the vast majority of the heart is actually ventricle. It's the pumping chambers. The 2 little atria are actually just like little chicken wings at the top of the heart, and they collect the blood, but they don't do much more than just collect the blood. When you hold a heart, the vast majority of it is ventricle. It's the massive muscle that pumps on the left side to the body and on the right side to the lungs. So if you remember your circulation of the blood, the large circle, the left ventricle, pumps blood that's filled with oxygen to the entire body, and then it returns back, and when it comes back into the right atrium, then drops down into that smaller circle, the right ventricle, and that is a smaller pump. You can see it's a smaller circle, and that pumps blood that has no oxygen in it but is high in carbon dioxide and pumps that to the lungs. The lungs exchanges it. The carbon dioxide goes into the lungs. The oxygen goes into the pulmonary vein, and then it returns back to the left side of the heart, goes into the left atrium, and then drops back down where it repeats from the left ventricle back to the body. Even though the heart is filled with blood, it doesn't get its own blood supply from the inside of the heart. It gets it from the coronary arteries on the outside of the heart. In a healthy heart, the coronary arteries are wide open and the blood flows down each of the coronary arteries to all the different parts of the heart. Over the years, the heart can develop coronary artery disease, CAD, in which plaque builds up inside and narrows the channel, making it more difficult for blood to flow through the coronary arteries and get to the heart. So narrowed coronary arteries can lead to angina. Sometimes a coronary artery can actually become completely blocked by a clot that gets stuck in that narrowed coronary artery. And that's called an acute myocardial infarction, or as you've known it all your life, a heart attack. Patients with coronary artery disease often get chest pain or pressure when they exert themselves. As the heart works harder, the heart needs more blood and more oxygen than can be supplied by the narrow coronary arteries, and this causes the chest pain. This chest pain is called angina pectoris, or sometimes just angina. And there's stable angina, or angina, and unstable angina. The stable angina is predictable. So every time you walk up 3 steps, every time you go around the block, you get the chest pain. And what do? You sit down and rest, and the pain goes away. Sometimes you're given nitroglycerin and you place that under your tongue, and that dilates the coronary arteries and helps the pain to go away. As the narrowing gets worse, the patient can have unstable angina, in which the chest pain can occur at any time. You can be watching television and all of a sudden you get the chest pain. You can be woken out of a sleep with the chest pain. Patients who can't manage their episodes of angina chest pain with nitroglycerin may have a balloon angioplasty performed. They insert a guide wire, then inflate a balloon inside the coronary artery, and then hold it open with a stent, which is a wire mesh tube. When a patient is having a heart attack or an acute myocardial infarction, and there's a complete blockage, they can do an angioplasty as well and go in and actually remove the clot and basically make the heart attack as if it didn't happen. Angina pain will often go away with rest and nitroglycerin. A myocardial infarction or heart attack pain will not go away with nitroglycerin. Fortunately, the treatment for angina or a heart attack are both the same. Place the patient in a position of comfort, usually semi-sitting or Fowler's. And then if their oxygen level is below 95% or the patient has shortness of breath, then give them oxygen. But otherwise, you do not need to give them oxygen. If there are no allergies, you can give the patient an aspirin and have them chew it. The dosage should be 160 to 325 milligrams, which is 2 to 4 baby aspirin or 1 adult aspirin. Depending on local protocols, you can administer or assist in administering the patient's nitroglycerin 0.4 milligrams, sublingual under the tongue, every 5 minutes up to a total of 3 in 15 minutes. Now remember, there are contraindications for administering nitro. One of them is having a blood pressure below 100. So after you give the first nitro, before giving a second nitro, you have to take the blood pressure. If the blood pressure is below 100, you can't give that second nitro. Another contraindication for the use of nitroglycerin is the recent use of erectile dysfunction medications, such as Viagra or Cialis. If the patient takes the first nitroglycerin and becomes pain-free, you don't have to administer a second dose, and you can pretty much assume that the patient is probably having angina and not an MI. Remember that you don't have to determine whether the patient has angina or an MI, because the treatment is going to be the same, and the signs and symptoms may be the same. All of them may have chest pain or pressure. Pain may radiate to the neck or to the jaw, to the arms. They may or may not have shortness of breath, and they may or may not have had a history of taking nitroglycerin, but the treatment is still the same. Before we begin looking at congestive heart failure, let's take another look at the heart and look at it in a slightly different way. The heart is actually two pumps. There's a right-sided pump and a left-sided pump. The right side collects blood from the body. It's low in O2, high in waste, carbon dioxide, and then it pumps the blood to the lungs to pick up more oxygen and drop off carbon dioxide. The left side of the heart collects blood from the lungs. It's high in oxygen, low in carbon dioxide, and it pumps the blood to the body, dropping off the oxygen at the cells and picking up the waste, the CO2, and returning it back to the right side of the heart. So this helps us when we start talking about congestive heart failure. Because if the left side of the heart fails, then the blood backs up into the lungs and causes pulmonary edema, the crackles you hear on lung sounds. If the right side of the heart fails, then blood backs up into the neck, jugular venous distension, and blood also backs up into the legs, pedal edema. Because the left side of the heart is larger and does the most amount of work, that's the side that fails most of the time. But yet you see all three in congestive heart failure. That's because the right side of the heart is much smaller and it can't pick up the job of pumping for the entire left and right side. So if the left side fails, the right side fails. So you actually see all three symptoms and signs. You see jugular vein distension, you see pedal edema, both signs of right-sided heart failure, and then you also hear fluid or crackles in the lungs, which is the sign of left-sided heart failure. It's important to be able to recognize heart failure with pulmonary edema. It comes on quickly and patients can crash very quickly. As you walk into the room, you may be able to hear the crackles without a stethoscope. The patient's skin will be diaphoretic, which is sweaty. The patient will be very frightened and struggling to breathe. They're literally drowning in their own fluids. It's important to begin treatment for your congestive heart failure patient quickly. Put the patient in a position of comfort, which for them will be sitting as high up as they can. They may even want to take their feet and put their feet on the floor of the stretcher so that they can sit further up. Give the patient high flow O2 by a non-rebreather mask, and if local protocols allow, you could use CPAP, continuous positive airway pressure mask, which is very effective in pulmonary edema. Depending upon local protocol, you may be able to administer nitroglycerin, 0.4 milligrams sublingually every 5 minutes, or according to the frequency determined by your local protocol. Remember, it's still contraindicated if the blood pressure is less than 100 or if there's been recent use of erectile dysfunction medication. Finally, if the patient has had chest pain and it's approved by local protocol, you may also administer aspirin 160 to 325 milligrams chewed. En route to the hospital, you'll have to encourage your patient to continue to take deep breaths. He's going to be working hard to breathe and may ultimately give up. If that happens, you need to lay him supine and begin assisting his ventilations with a bag valve mask. Let's do a practice question. So stop this video, read the question, and then start it, and the next slide will show you the answer. So answer A is incorrect because you shouldn't be giving oxygen since the pulse ox is 96%. Answer B is correct. You need to ask about any recent erectile dysfunction medication, and Viagra is one, so you will need to know the basic names. Then C is incorrect. Again, same problem. You shouldn't be giving oxygen if the SpO2 is 96%. And D is incorrect because the patient's allergic to aspirin. A less frequent condition you should know about is an aortic aneurysm or dissection. The patient's aorta actually begins to tear on the inside and creates a swollen area. It can happen anywhere in the thoracic cavity or actually in the abdomen, in which is called an abdominal aortic aneurysm. Symptoms include a tearing type chest pain or abdominal pain, usually worse at the onset. And if you palpate the abdomen and it's an abdominal aortic aneurysm, you may feel a pulsating mass that beats each time the heart beats. Treatment includes a position of comfort, O2 if needed, and careful transport. In sudden cardiac arrest, the patient collapses suddenly to the ground. You check for pulse and respirations, begin CPR, provide oxygen, and get an AED as soon as possible. A few other terms that you need to know. Cardiac compromise is just another name for acute coronary syndrome, so you should be able to recognize either one of them. The next term is cardiogenic shock, which we talked about in an earlier video. The heart fails to pump blood effectively, like in congestive heart failure, and it leads to an inadequate tissue perfusion, which is shock. The third term is a dysrhythmia, and a dysrhythmia is an abnormal electrical rhythm in the heart. So if you look at the left at the bottom, that's a normal sinus rhythm, and that's a normal rhythm. A dysrhythmia, which would be deadly, is the one on the right, which is ventricular fibrillation or VFib. Remember to read the questions slowly and carefully, disregard the distractors and answer the question that's being asked, and of course study hard and do well.